So as Tom said, the title of my talk is Hemodynamic Significance of Coronary Stenosis in Patients with Chest Pain Using Fusion of CT Angiography and 3D Echocardiography. And I added a little subtitle, and I will explain why, and it says, Challenging the Conventional Wisdom, ? So I'll start by challenging the conventional wisdom by right away thanking my colleagues, Amit, Patel, Roberto, who are true partners in crime, without whom the study would never have happened, and also Dr. Francesco Maffessanti, who wrote the software that you will see, and a number of wonderful imaging fellows who have been enrolling patients into the study and imaging them, without whom the study would have never taken off as well. So my disclosures are, and this is a very important disclosure which I am very happy to talk a little bit in details about. My first disclosure is a research award from the ASC Foundation that Dr. Porter mentioned a minute ago, and I wanted to, again, to take the opportunity after 3 years of continuing support from the foundation to thank the foundation. And there is actually a little bit of a story that I wanted to tell you, that as you probably have noticed, the ASC logo and ASC Foundation logo has a big heart in the middle of it, and for years and years, I was living under the impression that this is because we image the heart. It took me a few years to figure out that there is a better reason for that, and the reason is that especially the foundation and the ASC as well represent an organization of people with big hearts, and this is from the bottom of my heart. I thank the ASC Foundation for supporting this study. As you know, in the United States alone, every year over 8 million people require emergency evaluation for acute chest pain, with estimated cost of over $10 billion. In this context, combined evaluation of coronary anatomy, namely presence and severity of stenosis, and its hemodynamic significance, namely presence and extent of ischemia, is truly essential. This is frequently addressed by downstream nuclear stress testing in patients with abnormal CT coronary angiography, especially those with intermediate grade stenosis, when we really are not sure how to proceed in terms of treating these patients. And obviously, alternative approach that do not involve stress and or radiation may result in fewer unnecessary tests, greater patient safety, and significant savings as well. We focused in this study on fusion imaging. So what is fusion imaging? We hear about it once in a while. Sometimes it's referred to as image fusion or hybrid imaging, and it's basically combining images of the same object from different modalities or different types of information from the same imaging modality into a single display. For a while, we kind of looked at fusion imaging as a solution that was around looking for a problem. But then we had an idea of actually using this, and the slide would be nice if they advanced. Fusion imaging is not really new in cardiac imaging. This is an example of a paper from a decade ago, in which the authors created beautiful images of the heart from CT, on which they superimposed stress perfusion maps from nuclear imaging. This is not the last time this happened, although the number of publications is relatively small. And today we all see fusion imaging being of 3D echocardiography with fluoroscopy is being routinely used to guide interventions for structural heart disease. We focused our efforts on fusion of 3D echo with CT angiography. And the question that we wanted to answer was this idea useful for the evaluation of chest pain? Specifically, we focused on systolic strain, which is an echo-derived parameter we all have heard about and know about. And this is the parameter of myocardial function, and we know that from multiple publications that myocardial longitudinal strain can be used to detect subclinical dysfunction in the presence of normal ejection fraction and normal wall motion. So the question was for us whether this parameter was sensitive enough to detect ischemia whether resting strain was sensitive enough to detect ischemia in patients with chest pain when it's there. So our hypothesis was whether fusion of 3D echocardiography derived resting myocardial strain with coronary anatomy from CT angiography might allow fast and inexpensive and accurate determination of hemodynamic significance of coronary stenosis in patients with chest pain. Our specific goals in this study were to develop a computer analysis technique that would generate parametric displays of strain from 3D images and fuse them with CT-derived 3D renderings of the coronary arteries. And the second goal was to determine whether abnormal resting myocardial strain in patients with chest pain could accurately reflect hemodynamic significance of coronary stenosis in the corresponding artery using coronary fractional flow reserve as a reference standard. So what is the added value of fusion in this story? So, and I would like you to look at these images carefully. So on the left side, what you see is a perfusion map. This is stress perfusion map, subendocardial perfusion from CT fused with coronary arteries, and you see how it rotates, and you can see it from different angles, etc. On the right side, this is a strain map, longitudinal strain map that is superimposed on the left ventricular surface, derived from 3D echo. It's also fused with the coronaries from CT, and you see how the heart is beating and the strain evolves throughout the cardiac cycle. And by looking at these images, I would like to believe that you would agree with me that fusion may allow the visualization of each coronary artery and strain or perfusion in its territory, lending itself to direct identification of the culprit artery when an abnormality is detected. So to test this hypothesis and achieve these goals, we enrolled patients referred for CT angiography who agreed to have an echocardiogram. In addition, echocardiographic imaging included 3D imaging, myocardial strain analysis, and a generation of color-encoded 3D strain maps. CT imaging, on the other hand, included standard clinical protocol to determine the presence and severity of stenosis and to generate 3D renderings of the coronary arteries, which you have seen in the previous slides. In addition, we performed vasodilator stress with regadenoson to generate maps of subendocardial X-ray attenuation, which were used to reflect a stress perfusion. And in addition, finally, images that showed luminal narrowing of over 25% and coronary and at least one coronary artery. These images were sent for CT FFR analysis by heart flow to obtain a reference for hemodynamic significance. Now, what is the CT-FFR? CT-FFR, as some of you have heard next door in the previous session, explained very nicely by Dr. Scherer. This is a technique, a novel technique based on computational flow dynamics that allows us to obtain FFR values in each artery at different levels of the artery and measure them quantitatively. CT-FFR has been validated against invasive FFR measurements with vasodilator stress, and it's a very well accepted technique. What you see here is how in one patient on the left side with no significant stenosis, all the FFR numbers are high, and in the patient on the right side of the slide who had significant stenosis in the proximal LAD, you can see how the colors of the artery change and become red gradually, and the numbers go down, and significant stenosis is considered wherever we see FFR value under 0.80. That is abnormal. So I mentioned that we measured strain in the study. So strain we can measure in 3D strain we can measure at different levels. We can measure it locally in any point of the myocardium, as you see on the left side. And for most of us, this would be too much information, you would think initially, but remember my challenging conventional wisdom with a question mark. I will get back to that in a moment. We can also measure it on a segmental basis, which is what every one of you, I assume, most of you would expect us to do. And we can also measure globally, which is somewhat irrelevant in this study if we're looking for a coronary, for a regional ischemia, so this would not work. How did we detect abnormalities then in this study? We performed visual analysis of strain abnormalities in the territory of each artery. We then, in addition, did a visual analysis of perfusion defects in the territory of each artery, and eventually we attempted segmental quantitative analysis of both strain and perfusion, and I will show you in a minute where that took us. When we saw abnormalities, we obviously wanted to validate whether they should be there or not, and whether there are true or false positives or negatives, etc. So we did several things at several levels. We first looked at the frequency of strain abnormalities in territories of arteries with significant stenosis and compared it to the frequency in arteries without stenosis. We also looked at the relationship with the presence and severity of stenosis on CT angiography, also at the relationship with the presence of perfusion defects on CT, at stress, and also at eventually agreement with coronary CT-FFR. And the results are that so far we enrolled, this is an ongoing study, we're not done. We enrolled 77 patients with 231 coronary arteries that were evaluated in the study. This is a breakdown of arteries by levels of stenosis, and also some numbers about how many patients had resting abnormalities in how many arteries, and how many patients had perfusion defects in how many arteries. And also I need to tell you that of the patients who had over 25% stenosis in at least one coronary artery, 21 underwent CT-FFR analysis, which means 63 arteries total. What did we find? So these are images of perfusion on the left and strain on the right side in a patient with normal coronary artery. And what you can basically see is that both of these parameters were relatively uniformly distributed throughout the myocardium. In contrast, in a patient with significant stenosis and abnormalities in the area supplied by the affected artery, you would see a less uniform distribution of colors. And as in this patient, you can see this perfusion defect on the left side that is nicely following the course of, the mouse is very difficult to move here. I apologize, I won't be able to point at things. This artery had a 70% stenosis in the proximal RCA, and you see the shape of this defect that basically follows the shape of the artery. And on the right side, you see that there is a strain abnormality that does the same thing. And please remember that this is stress perfusion as opposed to resting strain on the right side. So this is interesting. This is becoming interesting. A question is it always like that, beautiful and simple? I wish. Of course not, but if we looked at, as I said, we looked at frequency of these findings, and what we found was that in arteries with no stenosis over 50% and no perfusion defects, which we considered as normal, about 20% of these arteries had resting strain abnormalities. So these are our false positives, 20%. And I'm saying false positive with a reservation that I will explain in a second. In contrast, in arteries with stenosis over 50% and stress perfusion defects, which we considered hemodynamically significant, resting strain abnormalities were considerably more common and appeared in about 60%, which is 3 times higher prevalence. So this was encouraging, but we wanted to quantify these findings. So what we did was segmental analysis. As I said, you would expect to see that, and this is exactly what we did. But to our surprise, we found that the agreement was poor. And it took us a little bit of an effort to understand why. And the reason for that was that when we applied 18 or 16 segments, these conventional segmental models, this is what we see. We see that many times when there is a strain abnormality, our segmentation divides this defect into 4 segments. And basically, when you look inside each of the segments, you have a little piece of the defect, but you have a lot of tissue where strain is normal. And when you average that together for the entire segment, then you lose what you are so clearly in this case can see with your eyes. So the question was obviously, is the 17-segment model the best way to handle high-resolution images like this? And the answer is probably not. One might say, yeah, but this information is unvalidated. We don't know what this image means. How do we know that this is a real defect and we're truly splitting it into segments and losing it by doing so? So to test that, we looked at a subendocardial perfusion, and we looked at agreement between that and a coronary angiography, stenosis and coronary angiography, and what we found was basically the same thing. This is a perfusion defect that very nicely follows the course of the LAD down towards the apex, and when you divide it into segments, you see the same thing, that this defect it appears in different segments, and in every segment there is part of the segment that has normal perfusion, and when you quantify this, you don't see any perfusion defects. Everything there's nothing black or white, it all becomes gray. So the conclusion was that rigid segmentation often does not respect the individual coronary anatomy while splitting perfusion or strain abnormalities between several segments and effectively diluting them by normal perfusion and strain in other parts of these segments. So as paradoxical as this may sound, visual assessment of the combined color-encoded displays of thousands of pixels that contains highly refined quantitative information seems to be better suited for clinical use than 16 or 17 or 18 numbers that are affected by these partial volume effects. So let's see what the comparisons gave us in terms of accuracy of detection of whatever we're looking for. So this is a patient with a 70%, under 70% stenosis in the proximal LAD, and what you can see here on the right side, this is a strain map, and what you can see is a massive strain abnormality in the territory of this artery, while in the lateral wall and the rest of the myocardium, there is no defect and everything looks normal. So again, beautiful. How accurate is this if we apply this idea to all of our patients? And then what we get is sensitivity of 0.61, which is really disappointing at first look, but specificity is a little bit higher, which is encouraging because it means that if it's there is a reason for it to be there. So after initial disappointment, our question was, but do we really want it to be very high? Because if we wanted it to be high, let's assume that our sensitivity, specificity, and accuracy are perfect 1. What does it mean then? It means then that we don't need strain because we don't need echo. Because if this is so, we don't need echo and strain to detect coronary stenosis. We see coronary stenosis on CT. We would not be doing this. But this is not really a very relevant comparison because we're not looking for stenosis. We can detect it without echo. What we're looking is for significance of stenosis, of what does it do to the myocardium. That is the question. So the truly more interesting reference is not the CT angiography and the degree of stenosis. It is actually FFR. So here's another patient, and this is a patient who had a strain abnormality, as you can see in the middle here. This patient had a distal circumflex lesion, and you see on the right side there is a very obvious perfusion defect at vasodilated stress, and you can also see that the CT-FFR showed a very significant stenosis with FFR of 0.71. So this is what we want, and here I would like to have accuracy of 1. Do I have it? I wish. No. Of course not, but because nothing works that way in medicine, as you all know. We still have our sensitivity is higher here, and it's better, but we have to remember that we're talking here about resting technique. We're chasing a very elusive goal because we are trying to detect ischemia with resting echo. And that has never happened yet. Nobody was successful by any means that I'm aware of to do so. So I'm not really surprised that the sensitivity is rather low. But it's also important to really appreciate how low or how high it is. We need to compare it to something that is relevant. So to compare it to something that is relevant, we looked at how our stress perfusion compared to either CT angiography or, and I'm going to, for the sake of time, I'm going to go a little bit faster, I'll skip this one, and to CT FFR. So stress perfusion theoretically reflects a significance of stenosis, right? And FFR is the gold standard now, at least in our study, for significance of stenosis. This is a really nice example. The perfusion is abnormal in the territory of LAD. It's normal in the territory of the other arteries. A stenosis is significant based on CT FFR of 0.69. Great. Is this going to give me a sensitivity of 100? I wish. Here's the sensitivity. 81. And specificity of 67. So, am I happy? Am I disappointed? Well, we need to remember, this is not a resting technique. This is a stress technique. So we really would expect to have a very high level of agreement between these two. But it's not very high. So what happens if I put our techniques next to the perfusion technique with different references in the same table? So all these, and I added also positive and negative predictive values here so that you can see. And you see the sensitivity, as you would expect, is lower than for stress because it is a resting technique, so we can't expect every lesion to cause ischemia at rest. If we did, we would be foolish. Doesn't happen. However, what is interesting here is that our specificity is right on par with stress perfusion. The resting strain is as specific as stress perfusion in this study with these numbers in the second column. And in addition, look at the negative predictive value. It's really, really high. So this is a very easy way and inexpensive, and even compared to stress perfusion, it's a good alternative for a very simple reason. The echo does not require any additional radiation, and there is no stress test here. So we don't need to stress patients, and we do not need to irradiate them. All we need to do is get a 3D echo and analyze that. And this is why the conclusions are that fusion imaging provides a unique opportunity to view different types of clinically relevant information without the need to mentally co-register them within the complex anatomy, 3D anatomy of the heart. And this is not negligible, this is important. Fusion of CT angiography with 3D derived strain is feasible and may provide easy to interpret combined displays of coronary abnormalities and their functional impact without additional ionizing radiation or stress testing. This approach may prove useful for the evaluation of hemodynamic significance of coronary stenosis in patients with chest pain. We believe so. And further studies are warranted to further explore this approach using other relevant reference standards, especially in patients with intermediate grade stenosis who might benefit from an alternative like this more than anybody else. And before I say thank you, I want to show you this slide. And this slide is here because this is an example of very successful fusion of this dude in his t-shirt with the napkin that has a black tie on it. And why is that? Because when you look at it, I want you to remember that not always what you see is what is really there, and that fusion can be very useful sometimes in certain situations, but we have to take it always with a grain of salt before we make a clinically impactful conclusions. And with this, I would thank you for your attention and for being here at this time.